Assalamu alaikum. My name is Dr. Ahsan Ali. As we know, there is discussion going on UTI. Today, my topic of discussion is urolithiasis and UTI. First of all, learning objectives. We will discuss about a relation between stones and urinary tract infections, bacterial spectrum that cause urinary stones, uncomplicated and complicated UTI, and management options. Relation. This is sort of a vicious circle, but if it is not, but then still they are interrelated. Urinary tract infection caused by certain microorganisms or the urine stasis, or if there is obstructed system, this may result into urolithiasis. The stones that formed act as a nidus for infection, and that again cause UTI, and the relation or circle goes on. Stones due to urinary infection caused by certain microorganisms that are known as urea splitting organisms. These are Proteus mirabilis, Pseudomonas, Providentia, Klebsiella, Staphylococca, and Mycoplasma. With the help of urease enzyme, these organisms split urea and cause high concentration of ammonium in the urine, resulting in alkaline pH. The elevated pH greater than 7.19, in this pH the crystals in the urine precipitates that was soluble in normal urinary pH range, that is 5 to 7. Foreign bodies like Foley catheter or stents, neurogenic bladder also predispose to urine infections and stone formation. Infection with urea splitting or obstruction, synthesis of urease. The urease split urea into ammonia. The ammonia cause alkalinization of urine that form precipitations of crystals, and the bacteriolysis that goes on when they combine, they form nidus for formation of stone, and the result is stegon or stone formation, and that cycle continues. This is another diagram showing the process of urea splitting organisms and the procedure of stone formation. Like it's mentioned, these are Proteus, Pseudomonas, or any other uh, urease positive organism. They hydrolyze urea and form ammonia, and ammonium and hydroxyline the alkaline urine. The dissociation of phosphates and then precipitations of these crystals takes place. Now there are types of stone that are associated with UTI. Most commonly these are magnesium ammonium phosphate or struide stones, calcium phosphate stones, and rarely matrix stone can also form by the urinary tract infection with urea splitting organisms. Any stone, however, can be associated with infection secondary to its obstruction and stasis proximal to the offending calculi. The urinary tract infection cause alteration in urinary pH, ionic strength, solute concentration, complexification. All these factors promote stone formation. When we talk about steroid stone, they are also the MAP stone or magnesium ammonium phosphate, and they are almost synonymous with infection stones. They are composed of magnesium, ammonium, and phosphate, triple phosphate crystals. They are associated with urea splitting organisms. This is a diagram showing magnesium ammonium phosphate crystal. They are orthorhombic in shape. Urinary tract infection with urea splitting organisms cause increase in urinary pH that cause MAP crystals precipitations. The urinary pH of patient with magnesium ammonium phosphate stone is alkaline, and urease, this is the chemical reaction that showing the splitting of urea and formation of ammonium. Steroid stone present as renal staghorn configured calculi. They occupy renal pelvis and then extend into calyces. They are common in women and may reoccur after treatment. Preoperative urine cultures do not necessarily reflect bacterial composition of calculi. Means this is not necessary that the sensitivity we or culture organism we are getting in urine specimen match with the composition of stones that bacteria causing the stone. They seldom represent as obstructing calculi but carry high bacterial load and dangerous in high risk group like diabetic patient or immunocompromised patient. This is X-ray KUB showing image of steroid stones. This is a CT image that showing stones in right kidney. Now, women with recurrent non-E. coli urinary infection, since we know that E. coli is the most common cause of urinary tract infection, the woman with recurrent non-E. coli urinary infection, instead of appropriate antibiotic therapy, should be evaluated for steroid calculi. If he is been treating and coming again and again with UTI, then she must be sought out for any stone or steroid calculi. It is impossible to sterilize such calculi, but antibiotic can reduce urease level by decreasing bacterial load, can prevent recurrence, but stone removal is therapeutic. Acetohydroxamic acid inhibits urease, reducing urinary pH and decreasing chances of precipitations. Now, when we talk about UTI and stones, then we must know about the types of urinary tract infection. In uncomplicated UTI, this is UTI occurring in patient with structurally and functionally normal urinary tract. The majority of these patients are women, and it responds quickly to short course of antibiotics. Another type is complicated UTI. It occurs in patient having anatomical or functional abnormality, renal or bladder stone, or fistula between adjacent organs like rectovesical or VVF. It is common in men and take longer to respond antibiotics, and if underlying cause left untreated, then it will reoccur in days, weeks, or months. The complicated urinary infection should be considered potentially in diabetic patient, immunocompromised, if infection is hospital acquired, if patient is having indwelling catheters, history of urinary tract intervention, or not responding to appropriate treatment. In such situation, the UTI urinary tract infection should be considered on as complicated UTI, and it should be treated on those principles. Now, another type is isolated UTI, an interval of at least 6 months between infections. And second type is recurrent UTI. In recurrent UTI, there will be more than 2 infections in 6 months or three within 12 months. Then we will label it as recurrent UTI. Recurrent UTI, the cause can be due to reinfection by different bacteria, or bacterial persistence, infection by the same organism, originating from a focus within the urinary tract. The bacterial persistence caused by the presence of bacteria within the calculi, like we discussed steroid stone, or chronically infected prostate, obstructed or atrophic kidney. These all conditions, there will be nidus for infection, or there is any condition that store, or there is permanent presence of bacteria. When the antibiotic will stop, the infection recur and patient will come again. And urolithiasis is one of most common cause of recurrent UTI and unresolved infection. The type 3 is unresolved infection. It implies the inadequate therapy, that the appropriate therapy is not given to the patient, and causes may be natural or acquired bacterial resistance of bacteria or infection by multiple organisms, or there is rapid reinfection. Since urinary infection accompanying with stones fall into the category of complicated UTI, there are high chances of complications like pyelonephritis, pyonephrosis, renal or perinephric abscess. If a stone is present in urethra, there may be peripheral abscess or bacterial prostatitis. Patient with presence of stone can be an incidental finding in a patient with UTI. For example, patient come with complaints of urinary tract infection, and on workup on like ultrasound or X-ray, the patient is diagnosed with having stone. So it can be an incidental finding in a patient. A patient usually present with fever. Fever can be low grade or high grade, unilateral flank pain, or there is accompanied lower uretic symptoms like frequency, urgency, burning, dysuria. There can be flank tenderness. If UTI is complicated, there may be signs of sepsis. 20 to 30% of all sepsis are due to urinary tract infection. If there is a pyonephrosis has developed, then we may have a flank mass or examination, or there may be chances of azotemia if there are both kidneys are involved, or there is solitary kidney if obstructed or got infected with urinary tract infection. On investigation, we will advise urine DR that will show the presence of neutrophils, WBCs, and presence of RBCs. Nitrite will be positive. There may be proteinuria, presence of crystals, and bacteriuria. In culture, as we know, E. coli is the most common cause of urinary tract infection. There may be Proteus, Pseudomonas, Providentia, Klebsiella staphylococci, or all these are stone-forming microorganisms, urea splitting organisms. In case there may be sterile pyuria in case of stone and abscess of UTI. For example, the patient will have neutrophils in urine DR, but his culture will be negative. So stone could be there. And infected, urinary kidney is infected, so, and culture can be negative with the infected kidney is obstructed, because urine will be coming from the other kidney. And in case of genitourinary TB, there will be neutrophils in urine DR, but culture will be negative. So there are three conditions in which the urine DR will show infective picture, but we will not able to isolate organism in urine culture. X-ray QB, it will help to identify stones presence. It will be in kidney, ureter, or bladder. In case of emphysematous pyelonephritis, the gas shadows around the kidney can be visible. This is X-ray QB showing stone in left kidney, and distal ureteric stone is also visible. So on further investigation, we can identify the kidney is obstructed or not. Ultrasound can helpful in, first of all, the it can show the presence of stone, whether it is radiolucent or radiopaque. The kidney stone can easily identify on ultrasound. The presence of hydronephrosis, and if hydronephrosis is presence, there are echoes in it. For example, pyonephrosis, the condition of cortex, the kidney cortex is good, or there is thinning of cortex, or presence of fluid or abscess around the kidney. Now in CT scan, it is highly sensitive in identifying complication. It will helpful in delineate the anatomical or functional abnormality. If it can also delineate the presence of stone, number of stones, and stone is obstructed obstructing or non-obstructing. For example, a radiolucent stone or ureteric stone that we cannot identify on X-ray KUB, the CT scan can help us in identify the stone. Presence of pus, gas, or abscess around the kidney, level of obstruction, or if there is obstruction, and is the cortical cortex of kidney there is carrying or cortex is healthy. This is CT scan showing xanthogranulomatous pyelonephritis. This contrasts enhanced CT axial CT scan through the kidney, showing staghorn calculi. This is another CT scan showing stone in right kidney with gas shadows in the kidney that is diagnosed is the diagnosis is emphysematous pyelonephritis. So, since there is stone causing obstruction. Talk about management. If UTI is uncomplicated, means there is a first in first presentation and patient is systematically well and there is no other risk factor. We can treat UTI according to culture and sensitivity and plan definitive treatment for stool removal after investigations. If UTI is complicated and patient is systemically unwell, then resuscitate urine and blood culture should be sent. Start IV fluid, IV antibiotic according to hospital policy, and then start after after getting the culture and sensitivity, start the antibiotic according to sensitivity. Get X-ray KUB or ultrasound KUB to see stone, underlying abnormality, unexplained hydronephrosis, or if there is gas, pus or fluid surrounding the kidney. If patient does not respond within 3 days or there is findings on prior investigation like we are getting hydronephrosis on ultrasound or there is any pus present, then get CT KUB to exclude possibility of pyonephrosis, perinephric abscess or emphysematous pyelonephritis. Obstructing renal calculi can be confirmed by the CT urogram. After patient's condition become stable after IV antibiotics, change it to oral antibiotics according to appropriate sensitivity and continue antibiotics for approximately 10 to 14 days. Repeat or CT urogram after 2 weeks if needed. If patient's symptoms is not resolving and there is fever or patient is again symptomatic, then repeat investigations. Many cases of emphysematous pyelonephritis and pyonephrosis may end up in nephrectomy. When infections get settled and renal function preserved, then plan for definitive management for stone disease. Treatment options can be open or endoscopic depending on size, site, position of stone, and cortex of kidney. In case of endoscopic procedure, get sterile urine culture before procedure or start antibiotic before procedure according to hospital policy and local guidelines. It is better to get sterile urine before any endoscopic procedure because there are highly chance of urosepsis in endoscopic procedure if it is done with positive urine culture or in presence of uh, organism in the urine. Now we take a short look on urosepsis. Causes of urinary sepsis are most common causes: presence of manipulation of indwelling catheter or stents, urinary tract surgeries, particularly endoscopic. Endoscopic surgery are highly uh, connected or there are high incidence of urinary sepsis in endoscopic surgeries, or urinary tract obstruction mainly due to stones. The obstructed system may get infected and it can also cause sepsis in patient. The organisms involved in urosepsis almost same that cause urinary tract infection like E. coli, Enterococci, Staphylococci, Pseudomonas, Klebsiella, and Proteus. These all organisms can cause urinary sepsis. Management is early recognition. If patient is hypotensive or tachycardic or tachypneic or in uh, in CBC there are increased number of leukocytes, then patient should be considered to having chances of urinary sepsis. Resuscitation, localization of source of sepsis. It is very important to localize the or identify the source of sepsis. Sometimes it can be a catheter, or sometimes it can be a stent. Early and appropriate antibiotic administrations. Shift patient to high independency or intensive care unit if needed. The investigations will perform in case RCBC. It will inform about the HB level, count of neutrophils, and platelet counts. Coagulation screen for possible needed intervention. For example, if drain placement or nephrostomy tube insertion is needed, then coagulation screen will be needed. Urea and electrolyte to assess renal function or electrolyte imbalance. For example, an endoscopic procedure is done and water has been used, and then patients came to recovery or in ward and show the signs of sepsis. Then we should have idea about the electrolyte condition of patient. Urine and blood culture to identify or isolate organism and then treat infection accordingly. And then imaging guided by the X-ray findings. X-ray, we should as know that the procedure uh, has been done in anesthesia, general anesthesia. So there can be chances of atelectasis, and there is can be pneumonia or effusion. To exclude these cause of sepsis, we need the X-ray. Ultrasound to see stones, hydronephrosis or pyonephrosis if the kidney is obstructed. CT, if permissible and patient condition is stable, then CT can be done to identify the calculi, structural or functional anomalies in the urinary tract, or obstruction, or there is any pelvic collection. Then when we talk about the treatment, there will be general principle: airway, breathing, circulation. We will secure oxygen inhalation and IV access if needed. If not catheterized, then catheterize patient to monitor urine output. Empirical antibiotic therapy according to hospital guidelines, and if when culture is uh, achieved, then according to sensitivity. Manage comorbidities. If a patient is diabetic or hypertensive or any immunocompromised patient, then we have to manage its medical comorbidities. Treat the underlying cause, like if there is obstruction in the kidney, for then drain obstruction. If obstructing ureteric stone, then arrange nephrostomy tube for insertion. JJ stent can be insertion can be done if the patient condition is permissible. And it is important to send pus or urine for culture obtained after decompression. If a nephrostomy has been placed, the if pus has came out from the kidney or urine is came out from kidney, it is very important to send pus. It is very important to send culture of that specimen. Now the take home message is urolithiasis is one of the most common cause of complicated UTI. UTI with stone, most of the times it is fall into complicated UTI category. And urolithiasis should be excluded in patient having recurrent UTI without having any known risk factor or abnormality in urinary tract. For example, a patient is coming again and again with UTI and it is not resolving after appropriate therapy, then investigation should be ordered to uh, identify any underlying cause or presence of stone. After definitive treatment, the patient's UTI has been treated and the stone has been removed. The focus should be on prevention of recurrence of stone, through increased fluid intake, diet modification, and get stone analysis and metabolic studies of patient, and according to that the plan stone prevention. Untreated UTI with urolithiasis can result into complicated UTI, and it may result into pyelonephritis, pyonephrosis, xanthogramulatus pyelonephritis, emphysematous pyelonephritis, and renal abscesses. And it may result into loss of kidney in form of nephrectomy that will be done or needed in future. Since UTI urinary infection is major cause of sepsis, it also insert extra burden on healthcare setup through the hospital admission, expensive antibiotics, and intensive care. And in worst case, we might lose the patient. Being healthcare professional, we should focus on prompt and early treatment of urinary tract infection with urolithiasis to prevent complications. Thank you.
Right. So, in your list of take-home messages, one can add one more thing, just a single sentence, and that is there is no UTI which is without any cause. There has to be a cause. Either there is a pathology which is a cause, or there is a physiological process that is a cause. What I mean by physiological process is, for instance, in a female, we have got a 28 day cycle of hormonal concentration going up and down. And these hormones, they do make female gender susceptible to infection one way or the other. So that is one of the aspects of physiology. As far as urolithiasis is concerned, we can say in one sentence that either stone is the cause of UTI or UTI is the cause of stone. So, whenever you find a stone, you always must look for UTI. Other way around, if you find UTI, always exclude stone because you actually reside in an area where stone is much prevalent. So, whenever somebody works in any environment, in any country, in any culture, in any community, knowledge of that community and the lifestyle is very important. Unless and until a doctor, clinician, urologist has that knowledge, um, and he doesn't or she doesn't take credence or give importance to the cultural aspect, uh, the treatment will always be short of completion. So that is my understanding of working with patients with disease and treating patients. You have to have a knowledge about the background. You take history, you take a lot of things into consideration, for instance, lifestyle of the patient, in which environment the patient works, or what is the actual dietary habit. These things combined together make you understand what kind of a situation the patient is in, and that will make you a better clinician, a better diagnostic, a person with a better diagnostic ability. So first you have to diagnose and then you treat. The treatment is very simple. You take antibiogram into consideration. That depends upon the policy of the hospital in which you work. But again, uh, the first thing is you have to pinpoint those predisposing factors that lead to UTI. And this is one of the things that is urolithiasis.